Yeah, good evening, everyone. First of all, I thank Dr. Ladisa sir for taking out this time from this busy schedule to enlighten us on the another session of continuing medical legal education. So, sir, please begin with your. Sir is a urologist and president Urological Society of India currently, and is very busy traveling across the country. Sir, please begin.
Yeah. Thank you, Mahesh, for a nice introduction. And it is certainly a pleasure. It's certainly being a pleasure and honor to present my views on this. It's always a pleasure and a very hobby of mine to go for medical legal education for our doctor colleagues, in spite of whatever busy schedule I may have. I came yesterday from Srinagar and tomorrow I am leaving for Puri. So it was only today what day was available. That's why we fixed that, and it's a pleasure and honor. Today we will be discussing on the medical record keeping, which will be including the informed consent. Will be continuing including in both, because I believe for the surgical field and the anesthesia field, a valid informed consent is the most important single document which is important. So we will be discussing both. Now, the situation in last few years, not since the time we joined the medical profession, during our days, the things were entirely different. But nowadays, the fact remains, can you trust your doctor? And the doctor is God when the patient is ill, and the doctor is devil when he sends the bill. And that is the unfortunate situation as on today. The patient is cured, then the doctor is God, and the patient is mourned, then the doctor is fraud. So now you see the lot of litigations and all those things are happening, which was we never thought when we joined the medical profession. And I strongly believe nowadays practicing medicine in India is fast becoming just like that probably we need to learn all these things because it is becoming a adventure sport. In adventure sport of any variety, you would see there are at least few safety measures. But for practicing medicine in India nowadays, there are no safety measures and it has become an adventure sport. So there are no safety measures, and unfortunately, these situations are increasing day by day unabatingly, and there are no signs that it will reduce. So what exactly are the medical records? Because except for these few institutions and the medical colleges, 80 to 90% of the Medicare is being provided by the small and the medium nursing homes, where if you see what is the medical record, there are hardly any medical record that we will come to show. So now because of the various things, the litigations and all those requirements, we feel that it's a big another lafda for the doctors that they have to go for these litigations. Say, for example, I am a urologist. I have a lot of trouble. I do a TURP. Sometimes they bleed. Sometimes they would bleed at late in the night. I do PCN. They would bleed. You are doing so many of the things. Endotracheal tube you are passing, not going, patient becoming restless, tachypnic, and so on and so forth. There are so many of medical lafdas for us to deal with. And in addition, since last 30, 40 years, this has come, the non-medical lafda which has come for the doctors, as far as our thinking is, as far as the medical record keeping is concerned. So we are talking it about now because of the Medical Negligence Consumer Protection Act, which has come, and the number of litigations that has skyrocketed in last few years. So, but whenever I am saying you, we, I mean we, and I am very much included. I am no different than any one of us here. In pre-CPA era, before 1986, we were all God, super God, demigod, next to God, and I do not know what not. But post-CPA, at least for some of them, we have become Kader Khan, Shakti Kapoor, etc., etc. And even for them whom you are God, super God, still maybe because for few patients who become fine, you may still be God or super God or next to God. But from the 7-star category, now you have become a 2-star or 1-star category God. So we all have to understand and accept the very fact, a very painful fact, that this is a CPA, not DPA. This is a Consumer Protection Act, and not the Doctor Protection Act. So obviously, the basic tendency of the court, consumer courts, and especially the lower consumer courts, that is the district courts, state forum, state commission, and the national commission, probably may not be as bad. But for consumer forum, it is the attitude is very, very clear that it is a bias towards consumer. I'll just give you one simple example. You are driving your Mercedes on the straight road from the side in a comfortable speed. From the side road, one rickshawala fellow comes and is dashing against the side of your car, which can never ever be your fault. But his chakka gets bent. So what the onlookers are going to, which will collect 15, 20 people will collect there, what they are going to say, अरे साहब ये गरीब आदमी का चक्का बेंड हो गया है, प्लीज उसको तो 5,000 दे दीजिए. Almost the same attitude is in the consumer forum. So unless until your defense is watertight, you are going to face the music. But fortunately, Indian public in general is very docile. They are forgiving type. We are from the land of Gandhi and Mahavir, who believe in destiny. So over a period of time, their anger vanishes, and as many litigations should have been there are not there. So litigation needs a lot of perseverance. So most of the time, over a period of time, people, okay, let it go, and they forgive it. Another myth is there that the government doctors are not in CPA net. It is not like this. All the government doctors are under the CPA net, wherever even a single rupee is charged for whatever thing is there, except for an initial low-cost registration of 10, 20 rupees. Even the 5 rupees is taken for X-ray or sonography or a private room or something, then for one patient, all the patients become the consumer. But fortunately for the government doctors, even the lawyers and the patients believe that the government doctors are not in CPA net. So that is a big advantage to them. Like, see, in 1991, Lucchelo has said, compelling evidence that more malpractice is committed than can ever be recognized, litigated, or compensated. If you would see all around, because you are doing a good job, you are doing a conscientious work, so you would realize that why the finger is raised towards you. But ultimately, when you look around, all around you, you will see that most of our own cousin brothers and sisters are doing lots and lots of malpractice. So whenever we talk about all these things, what we in general feel that it can never happen to us, because I am practicing since maybe 30 years or 35 years or 40 years. It has not happened with me. And then I have a good relationship with the local people, local politicians, press people and all that. So we will take care of it. And that is what it is. And that's why the medical record keeping takes a back seat. We believe that it is not our neighbor. See, one of the cases where the compensation was more than 15 crore, Emory Hospital one, Kunal Saha versus Emory Hospital and other doctors. It was to the tune of almost 15 crores. And that was only because of the record keepings were not up to the mark. We will discuss in detail about this particular case. That in short, see, in general, there is a philosophy that if there are two schools of thought or two procedures which can be done, you adopt one of the procedures, and that is not negligence, unless until it is a 13th century old procedure. In this particular case, it was a 10 toxic necrotizing epidermitis, something like that is the word, I'm forgetting the name. And for that, you can use the corticosteroid or you cannot use the corticosteroid. The doctors there have used the corticosteroid. But the problem is that the dosage that he has used was beyond whatever is mentioned in the leaflets provided with the drugs or in the textbook and all that. It was beyond that. So that is where it was caught that, say, for example, thiopentol, you have to give 1 gram. And you have on record have written that 1.25 gram has been given. So that becomes an overdose and a medical negligence. So that was the situation. And because of that, the compensation was given. Dr. Were found negligent, and the compensation in 15 crore, up to 15 crore, including interest and all that, were given. Another case was Dr. Praful Desai. I do not know how many of you may be knowing Dr. Praful Desai. He was our examiner from Tata Cancer Hospital, a Padma Shri, and a very, very senior teacher, a very intelligent, very diligent director of Tata Cancer Hospital in Mumbai. And nobody can doubt his integrity, his knowledge, his skill, his experience, intelligence, diligence, whatsoever. But because of technical deficiency in the record keeping, the matter had gone up to the Supreme Court, and there was a criminal negligence issue against him, which was later on corrected, but civil negligence was not cleared for him. So the basic tenet of any medical science is first do no harm. And to err is human, building a safer health system. This was a study 25 years ago, 2000, this one, Institute of Medicine report. It was a very large sample, New York using 84 data and Colorado, Utah using 92 data. It says that adverse events are to the tune of 2.9 to 3.7%. And the worst thing is, they said 58 to 53% of adverse events were preventable. So that is where the big problem is occurring. That even if it was not a preventable one, the complainant will say it was preventable. And that is where the litigations will go. So in general, it is said, hey, India depends on God. Sometimes we believe that God also depends, with all due regards to Almighty. Maybe God also depends on India, otherwise might become jobless. Another thing is that there are no medical men in forum. This is a very, very common thing that most of the doctors say, okay, there is no fault of mine in this, there is nothing in there, what will be there? And there are no medical men in forum, what they will understand. Somehow the other, I feel that this is a blessing in disguise, because they would always decide the case depending on what exactly is shown to them. And if they are a non-medical person, it is much easier to be able to convince your point of view in this medical forum when the matter goes to the litigation. And normally what they say, and it is true also, that if the counseling is good enough, probably the matter would never go to the litigation, which occurs in maybe about 90% of the cases. But when the matter goes to the litigation, your counseling goes down the drain. It doesn't matter, because it is one versus one matter. Whatever you have said is not going to work. So what has been recorded, or what is in the medical records, that is going to keep whatsoever. So if you do the counseling, good counseling and good medical record, there are good chances that you will not land up into trouble. It is always said the good record will have good defense, poor record will have poor defense, and no record, God only knows. And like I said, most of the Medicare is being provided by 80 to 90% of the small, medium nursing homes, where the record keeping, maybe it has improved in last 5 years or so, but otherwise it was a very, very pathetic. And I would say the condition of the record keeping in these institutes, pathetic is a respectable word. It is worse than pathetic one. In general, the only record keeping which is available, or the only checklist which is available, is whether the money has been deposited or not. And that is the sad reality. So what exactly is the record? The record will be which is connecting the patient, the disease, the medicines, investigations, nursing home, hospitals, and the doctor. Whatever document is going to relate all these things is going to become the medical record. So basically, it is an outdoor case treatment, register, booklet, card. There is an exhaustive list which will have that. But for us, most important thing is outdoor case paper, indoor case records, informed consent, and discharge summary. These four are the more important things. Each and every other document is also important, but these are the main four important documents. And like I said about the consent, I'm including consent here itself. The consent can be implied when the patient is coming to the hospital. It simply means that there is a consent. When the patient is coming for a surgery, say for example, he is coming for an inguinal hernia surgery, a cold case, he is coming, getting admitted, and he is depositing the money, that simply means that there is an implied consent. But for any operative procedure, we need to have a written, valid, informed consent, because that is the minimum requirement. Surrogate consent will be for the patient, like who is not in a medical condition, mental status is not proper, or he's not in a condition to give the consent, or the minor or unconscious patient, and all that. If we talk about informed consent, but if you see legally and technically speaking, exact one, in India, we do not need the informed consent. Supreme Court, we will be coming to that, but Supreme Court has given a very, very clear one. What we need is a real consent. But let us understand and try to err on the informed consent side rather than on the real consent side. The consent should be valid, it should be legal, it should be by adult, and the patient should be in condition to give consent. A very important thing. It should be from patient himself and herself. See, I would say that since last 15 years that I have been taking these talks and all this and that everywhere, where I get opportunity to share my views. And I'm shouting from the rooftop that the patient himself or herself should be giving the consent as far as the non-emergency and proxy consent are there. But in spite of that, whenever I am seeing the cases where the litigation documents are shown to me, I still see at least 80% of the consent are taken by chacha, mama, bhatija, bhai, father, sister, somebody else other than the patient. And another very important aspect is that the consent should be free, without any force, undue influence, without any fraud or misrepresentation or mistake. The common thing, which word is there, misrepresentation, because commonly everywhere later on the patient and their attendant, when they go to litigation, they would always say that the doctor has said that it will be over in say half an hour or so, and you will go home and there would be no problem, it will be painless, etc., etc. So that fits into the misrepresentation that would make your consent invalid. This is the classical case of Samira Kohli, which has defined the situation in Indian scenario, what exactly is wanted from Supreme Court. When we go through the algorithm of the this consumer forum decisions, you would realize initially it was simple, that you have done a hysterectomy and there is a VVF. Patient is not happy, they go to the court. You show them the textbook that this is a known complication of hysterectomy, and the chapter was closed. Later on, the thing started that, okay, it is a known complication, but did you tell the patient? Had you told the patient beforehand, patient might have withdrawn the consent and would have not gone under that. So that becomes another angle. So over a period of time, it becomes very difficult about what to tell and what not to tell. The surgeon would always feel that if he's going to tell about each and every possible complications, no patient will be lending to the table. And all anesthetists will become jobless. So fortunately, in 2008, this particular decision came, which I would suggest almost 98% made it clear what exactly is wanted in Indian scenario expected by Supreme Court as of now. This was a 44-year unmarried female. She was having menorrhagia. The exact word on the consent was diagnostic and operative laparoscopy, laparotomy may be needed. When the patient was taken for anesthesia and the procedure, they did the laparoscopy, and Dr. Manchanda found that there is an extensive endometriosis, and she wanted to proceed for the hysterectomy and bilateral salpingo-oophorectomy. So the junior doctor went out and took the consent from the mother. Naturally, the hysterectomy was done. Later on, the patient and her fiancé created a lot of havoc, that the surgery and the uterus was removed without their permission. From one court to another one, and then to the Supreme Court it went. The Supreme Court felt if laparotomy includes hysterectomy with bilateral salpingo-oophorectomy, then what was the need to take separate consent from the mother? So what the doctor should have done, in opinion of the Supreme Court suggests, doctor should have brought the patient out of anesthesia, taken consent from the patient herself, and then should have performed the hysterectomy. When you read the judgment, in short, whenever you are listening to this, it appears that your wings have been clipped and so on and so forth. But if you read the full judgment, it is a 44-year pages judgment. If you read the full judgment, you will feel proud of our Supreme Court judges. They have given a very, very balanced judgment about the scenario which is present in Indian scenario, seeing the socio-economical and educational standards of the patient. They have not given it totally like this. What they have said is that if it is an emergency or a life-threatening situation, you can proceed to do whatever is necessary. Then there is no separate consent needed. Say, for example, you are doing a cesarean section, and the patient bleeds profusely. You try everything, but you are not able to control. Then, as a life-saving measure, if you have done a hysterectomy, no separate consent is required for that. And similarly, they said there is a health preserving situation. Say, for example, you have done a laparotomy for pain in abdomen and you find the gangrenous bowel. Then you don't need to go and take a separate consent, because if they do not give consent, what you would do? You cannot close the abdomen. So you have to resect the bowel and do the anastomosis and proceed and inform the patient. But one thing is also said that if you anticipate such a situation, then take specific consent preoperatively. Like for urology, it is very common that there is an outlet obstruction patient are there. We do a cystoscopy, assuming that if it is a stricture, we will cut open the stricture. But if you find a bladder neck obstruction, then to do the bladder neck incision, the patient may become infertile, he may get retrograde ejaculation. So if you are anticipating that this is possible, then you can take the preoperatively consent itself. That if you find like this, we will proceed. If they say yes, you can proceed. This has happened basically with the situation, keeping in mind with the cardiology. There is a lot of advertisement that you will see from the corporate hospital, angiography in 5,000 or 8,000 rupees. And once the angiography is done, the doctor or somebody will come out and they say that there are 2 blocks, deposit 2 lakhs, otherwise we are not responsible. We need to put the stent immediately, else we would not be responsible. Seeing that condition, this judgment has been put into that. So the basic consent in this one is that the ingredient of the consent is nature of treatment should be there. All possible alternative must be explained to them. Then the risk and benefit of each and every possible alternative, and the risk of not taking that particular procedure. And there should be opportunity for the questions, and there should be sufficient time for the patient to digest whatever you have said and to be able to withdraw the consent if they want to. So like I said, consent has to be from patient himself or herself. A doctor has to secure the consent of the patient before commencing a treatment. It should be real and valid, should have capacity to consent, it should be voluntary, and it should be based on adequate information concerning the nature of treatment procedure so that patient knows what he's consenting to. It cannot be like that I permit Dr. Lalit Shah to do whatever he feels is okay. That days are gone. Now it is required that you have to have a procedure-specific consent for the procedure to be done. The doctor should disclose the nature and the procedure of the treatment, its purpose, benefits, effects, alternative, if any are available, outline of the substantial risk, and adverse consequences of refusing the treatment. That is also very important. So, say for example, basic idea of Supreme Court had been don't frighten a patient into surgery and don't frighten a patient out of surgery. I will just give you a simple example about, say for example, one patient has a ureteric stone of 3 mm, 4 mm size. He gets a ureteric colic. He goes to a general practitioner. He give him some injection. Patient becomes fine. A sonography shows a stone in the lower ureter, 3 or 4 mm. Then obviously the patient is either referred or he himself come to a urologist. And if the urologist, now 3, 4 mm, 99% should pass off over a period of time. But if your patient is going to call him and tell him that if we have to do a ureteroscopy and remove the stone, otherwise your kidney may fail and you may have more problem of the renal failure and you may die, or so on and so forth, that means you are frightening a patient into surgery, which is not desirable. And similarly, one patient who has come for a villager who has come from a hydrocele surgery, and if you are going to talk about a possible pulmonary embolism, that means you are frightening him out of surgery and he will lose the benefit of the surgical procedure that he may have. The consent for diagnostic procedure cannot be considered as consent for therapeutic treatment. Consent given for a specific treatment procedure is not valid for conducting some other operative treatment. It cannot be that when you are doing a gallbladder and you can do the appendicectomy also. In market में ये होता था कि सर्फ की 5 किलो की बाल्टी पैकेट लेंगे तो एक बाल्टी फ्री मिलेगी. ये वो काम नहीं चलेगा. You have to take a separate consent. But exception, I said, is necessary to save the life or preserve the health of the patient. There can be a common consent for diagnostic and operative procedure if they are contemplated. There can be a common consent for a particular surgical procedure and an additional or further procedure that may become necessary during the course of surgery. That we can understand. Now, again, the lot of liberty has been given to the Indian doctors by Supreme Court in Indian scenario. Extent of information to secure the consent need not be of the stringent variety as in Canterbury. Canterbury is an American case where their pattern was there, where they have to inform each and every possible complications which are mentioned in the textbook or literature or which the doctor is aware, but should be of the extent which is accepted by normal and proper. It will depend on the physical and the mental condition of the patient, nature of the treatment, and the risk and the consequence of the treatment. Many times it is not very uncommon that when the cancer patient is there and we want to take him for some surgery, the family always takes that, okay, sir, उनको cancer के बारे में मत बताइए. Don't tell them about the cancer one. So that is something like that. That much liberty has been given to the Indian doctors by Supreme Court. But if you are hiding everything from patient also, attendants also, and everybody, then there is a problem. But one thing is also there. If there is a direct question, there should be an honest answer. So what is a direct question? It has been my experience many times after giving a 10 minutes so-called monologic talk about the various things and all that. In the end, the patient and their attendant are asking, "Saab, marunga to nahi?" Then you have to give an answer. Like if you ask yes and no, it can be yes. But in last 30 years or 40 years, it has not happened with me. We have done all the pre-operative workup. We have taken the medical consultation. We have done the ECGs. We have done the cardiogram. We have done echo. We have taken cardiologist's opinion. We have taken anesthetist PAC. So we assume that everything will be safe. So why should there be like this? So with the rider, we can console them. That is what is required. Supreme Court had said the common complications you have to explain. You don't have to talk about the rarest of rare complications. But unfortunately, Supreme Court fell short of telling how common is common. So what we assume is, in general, whatever are mentioned in the textbooks are common. Whatever are more than 2%, that is what we practice. We do not know, there is no deficient exact literature, but that is what we practice. Whatever is more than 2% complication, known complication, that is common. Or a very severe one where the life-threatening situation is there, that is what there. And to explain during the counseling to the patient, it is also very important that we take care about the socio-economical and educational standard of the patients and their attendant. If it is a villager and you are going to talk about the pulmonary embolism and all this, it is of no use. But say, for example, you are going to operate on Ambani's, then you have to go almost like an American pattern consent, where you talk about each and every possible things, you document each and every possible things and all that. The blanket consent, which we used to take probably during our student life, is gone. That I permit Dr. Alisha to do whatever is required under whatever anesthesia, that period is gone, over. It is also another thing is very, very important that it should be in the patient's own language, that the patient understands. Maybe over a period of time, our OPDs will be having something like this. And one more thing is there, because any consent is an agreement. An agreement is always between two parties. So it is the surgeon and the patient. So if the doctor's signature is not there, that consent is invalid. I was also not aware about this particular about 8 to 10 years ago. But in one of the cases, the judgment has come where the doctor's signature was not there and that consent was considered as an invalid consent. So it is very, very important. The doctor's signature in general signifies that you have been able to explain to their queries to satisfactory level and they do not have any more questions to ask. These are few examples. Here, 11-year-old was operated for infection in ear he ended in the facial paralysis. So the doctor and the hospital were held negligent, not making the ward fully aware about the risk and the after effect in the language understood by him. So signature on stereotype does not absolve any doctor from liability of fully explaining the nature of risk an operation may involve in common language understood by the common man. So that is also very, very important. So, like I said, I am also as good or as bad. Even my practice, as on today, is also like this. I have not been able to convert all my consent into the Hindi language, but I make sure that in spite of that, whatever is there, I ask them to write one line in Hindi by patient himself कि हमें बीमारी, बेहोशी और ऑपरेशन के बारे में विस्तार से बताया गया है. If it is written by the patient himself in their own handwriting, they cannot say that whatever is written is English, we do not understand, and it was not explained to this. And this particular sentence have saved me in one of the cases which was against me 4 years ago. Only this particular sentence had helped me because the patient and attendants had put in the litigation that we were not told and we were not informed. And when I showed this, that it is the patient signature and the attendant's countersign, that they have signed, we have told them and they have informed about each and everything. So why should we keep the medical record? Because that is number one, that is a medical requirement by the Medical Council of India and now NMC. And that is the best defense in the court of law if the matter goes to litigation. And this was one particular case, Muhammad Aslam versus Ideal Nursing Home. It was held not negligent as post-operative instructions were to avoid such rich food. Do's and don'ts were mentioned on the record. On the discharge ticket, it was very clearly mentioned. Hence, it was the contributory negligence of the patient and the doctor, and the hospital were not held negligent. In this particular case, this is the importance of informed refusal. Many times it happens when the patients are there, say, for example, acute. This particular case was rupture of appendix occurred due to delay in surgery. Informed refusal was not taken, even though patient did not consent for surgery, was the plea of the surgeon. But that was not excused, and the surgeon was held negligent. So that is the importance of informed refusal. So if the patient is not willing to do, most of the time it happens when we suggest a surgery, the patient and their attendant, whosoever is available, would say, oh, mera abhi my bigger uncle or father or elder brother or somebody else is going to come and we are waiting for him and then we will decide. So till that time, you are holding a time bomb in your own nursing home. So that should inform refusal at that point in time, record that the patient is not willing to take the consent and is not signing for the consent. In this particular patient, Amir Ali Shakir versus John Medical College Hospital, patient was only for some time, 6:15 p.m. to 7:40 p.m. But on the record, it was IV fluid, blood pictures were there, X-rays were done, neurosurgery reference was done, 19 bottles of blood were arranged, and documentation of all activity with reference to time was done. So that was not held negligent. And this is another very important case. Owner of nursing home called the surgeon to perform the operation. The patient died during the operation. Now surgeon says that I did not operate because there is nothing in writing. But the record we are saying in the contrary that the doctor had operated on him. So only surgeon was held negligent and the nursing home was not held negligent. And similarly, there was one more case. This is a joke in medical legal circle or truth, I do not know. They said a similar situation happened and the patient died on table. There was no consent taken. And as we know that the doctors have a lot of gray cells. So the surgeon and anesthetist thought that, okay, there is no way anybody can prove that the thumb impression taken is antemortem or postmortem. So they took the thumb impression of the dead body on the consent form. Later on, it turned out to be that the patient was MA in English. So whether it is a joke or reality, I do not know, but it is something like this. So that is what is happening, that the medical legal scenario in CPA has changed tremendously since the time we joined the medical college 50 years ago. Had we joined at that point in time, knew this, maybe a good number of us would not have joined the medical profession per se. So Like they said, the first one, whenever you will get a first notice or the first court case or something like that, is very, very painful, because it is not the question of what is happened. It puts a direct big question mark on your skill, on your experience, of your sincerity. And that is a very, very painful thing. There was one dialogue in one of the picture Yashwant called from Nata Patekar. It says, "एक साला मच्छर आदमी को हिजड़ा बना देता है." I can tell you one thing. When the first one was there for me, I myself have no shame in accepting that I was not able to eat and sleep for about a week or so. Because I was the first urologist here, I felt that I have been giving so much things to this area, and still the people are questioning me. It was a very difficult thing to digest. And that is what it happens. But this is not a part of the game. Like I said, it is said that the CPA, the burden of proof is on complainant. But unless and until, I tell you, unless and until your defense, when the matter goes to litigation, is fully watertight, you are going to be in trouble. Another thing is that the court does not take a good view where it appears that someone is hiding any possible piece of evidence which may help in proper justice. Many people say, I remember many of my colleagues had been saying, okay, we do not give them this chart ticket. So they do not know, they cannot prove that they have been operated here. It is not like that. Something or the other will be there. There may be some OPD prescription may be there, some investigations may be there, where the reference your name may be there, or something or the other will be there which can prove ultimately that it is there. And you take a view that I have not operated, and it is proved that you have been operated, you have been the one who has operated on the patient, you would be in a bigger soup, because then you are trying to cheat the court. Another thing is records are like scars. It reflects the quality of care. And what are the possible allegations? Various allegations are possible. Okay, the commonest is the doctor did not take care. They did not come. In the night when we called, it was not there. For the anesthesia, they would say they did not, they give the high doses. When the anesthesia was given post-operatively, there was no one to take care. There was no PAC was done pre-operatively. Nobody had seen. They did not take care. Something like that will be always allegations in there. And for the outdoor papers, we say that the duplicate one is the best and the prescription should be in the clear handwriting. Various things are there. The indoor case records, it should be in the chronological order of progress of disease and treatment given, monitoring of this, pathological tests and reports, X-ray, sonography, everything. Very important from the surgeon and anesthesia point of view, pre-operative preparation, informed consent, detail of any procedure, surgery or anesthesia, which will include PAC, and date-wise record of investigations, and if there are references, opinion of various specialists. These are the very, very important documents. Record of informed refusal of treatment, investigations or surgery if the patient does that. And another thing is a discharge summary. I always say the discharge summary is the most important, is also one of the very important things, because the discharge summary, whatever has been documented into discharge summaries, goes with the patient, while the indoor record is with you. So it is a common thinking in the complainants, lawyers, and judges' mind, and probably true to some reality, that the indoor records can be upgraded or later on manipulated, or few things may be added. But whatever is mentioned in the discharge ticket, you cannot go to his home and change the discharge ticket. So every word in the discharge ticket is a gospel truth. Single word is not questioned. Whatsoever is written in discharge ticket. So it should be a very detailed discharge ticket, in a proper discharge ticket, and one should write about each and every possible thing, which can, if you assume that it will help in the court of law, if it goes to the matter of litigation. And very important thing is follow-up advice and review advice. In one of these very senior urologists from Delhi, because he did the procedure, he did a lithotripsy, sent the patient, he came for follow-up, he did the urine analysis, wrote some antibiotics and all that. And then the patient was lost to follow-up. He went somewhere else and took further treatment, and then they put the litigation. So the court said that the doctor had abandoned the treatment. The patient had not abandoned the treatment, because the patient was not called for review. So it is very, very important that all the patient, the last line, whether it is your OPD paper, whether it is a discharge paper, or it is a follow-up one, or whatever, last line is always call him for review for whatever period of time, 3 days, 5 days, 7 days, 1 week, 1 month, whatever is required. And moreover, it is good. The patient will come for review, he is going to pay you. It is a financially good also. Nothing wrong into that. Like I said about the informed refusal, very important. And then it is very, very important that records should not only be prospective, but should also appear to be prospective. Because it is thought in general, actually the complainant and the lawyer and the judges always think that most of the time the doctor's records are not perfect and they are not complete. When the notice is being served, they remove the file and then they update the records. All right. So what they happen is maybe 3 days, 4 days records are written in one go, one flow, all this. So the record should not be too perfect. It should not look like cooked and manipulated. It should not be in the same handwriting with the same pen and same ink in one flow. Fortunately, in Indian scenario, till now, I am not aware whether for record keeping, how old is that record, ink aging, handwriting expert opinion, or DNA fingerprinting is utilized till date, so as to know about when exactly that particular point in record has been made. So whether it was earlier or later on manipulated. Like I said about the discharge summary, and that I very commonly say it is very, very important that we need not necessarily remain only a good clinical diagnostician. In addition, nowadays, the time is where we have to become a reasonably good social diagnostician also, where we should be able to digest, have our sixth sense say that this is a trouble possible case. Out of 100, there may be only 2 trouble possible case, then it is much better that you send the patient somewhere else, refer him to higher center, stop your day's work, take an appointment to the higher center, and throw the ball in somebody else's court. 98% of the cases will be good enough to run your kitchen fire. Another thing that I have been following and I have been recommending since last few years is the discharge consent. Though this is not a very proper terminology, but this is something that I have been recommending. And this says that hereby we certify the discharge summary, investigations have been given to us, nature of problem, prognosis, plan of management, treatment given in the hospital, possible complications, failure, need for regular follow-up precautions, possible follow-up procedures, etc., have been explained to us to our satisfaction. If the patient and their attendants are signing this, it would always be a very good thing. Excuse me. Another thing is a periodic counseling record, especially in the ICU patient or a serious or critical patient or in high risk patient or a patient which was supposed to be normal but because of some reason or the other have become a critical patient. So that should be periodically recorded. Counseling should be done and it should be recorded. Audio visual recording is an additional thing, not only the paper recording. The hard copy is a must. Many times there are many people who are asking for the consent also for the operation. Is a video recording good enough? Video recording can be a bonus, but the hard copy is a must. Another thing about the consent is the timing of the consent. I remember in one of the cases, I will just give you an example. A patient was admitted on 9th in some nursing home for UTI, urinary tract infection. He was admitted, they investigated, they started the treatment and all that. And then they realized that it is because of the prostatic obstruction and he needs a TURP. So on 11th, 12th on, they referred me. I saw the patient. Patient was fine, has improved, and could have been taken for TURP on 13th. So I told them that tomorrow we will take the patient for TURP. When I reached to OT on 13th, naturally with my own habit, I asked the file and I saw the first thing about the consent. So there were 3 columns there, 3 things were there: patient signature, attendant signature, and witness signature. To my surprise, patient signature was not there. Attendant signature was there, and it was the date was put 12 of whatever month that was. And witness signature was on 9th of that month. God only knows what he witnessed. See, what happens in this, commonly speaking, what it happens is that the doctor and the attendants are not taking the consent or not bothering. It is handed over to the nurses to take that. In their opinion, it is very simple that they have to take 3 signatures. Whosoever is available, they would take the signature without realizing which should be the sequence of taking the signature. In this particular case, because the patient has gone for sonography and attendant has also gone for sonography, so they have taken the signature of the attendant, the witness on the day 1, 9th. Attendant signature they had taken because the patient had gone for ECG and PAC to the anesthetist. So attendant was there, so they have taken the signature when they decided about telling about the surgery. So the attendant had signed on 12th. And because of the apadhapi of this various things and all that, the attendant patient signature was not there. So that is also very, very important because that is not there. One simple thing, a simple answer to this is what we suggest and recommend is that make sure that you do not put date and time on the consent. When they are putting signature, let's avoid putting date and time into this. So that may probably adjust the mistake of the sequencing. Like I said, all prescriptions must end in the review. Now, the another question which is asked is, can record be maintained in electronic form? Yes, but for a few things, for OPD, consent, transfer or referrals, investigations, police cases, etc., should have a hard copy. These are the hard copies, various registers required by various authorities. These should be maintained in the hard copies. Otherwise, it can be maintained in electronic forms. Now, another question is how to correct the record. Many times we know that whenever we are writing, even whenever I am writing my operation notes, over a period of time, it's like, no, I want to correct this line. This line is not correct. So there is a standard procedure which is there. Cutting it in a manner that it cannot be read clearly is not proper. Putting the white ink over there and writing over that is not correct. So what is the legal way of correcting the record? Whatever line you have written, you can put a cross in one line, straight line, in such a manner that whatever is written can be read. That is very simple. Then you can write whatever line you want to add, and below that line, put your signature, date, and time. So then that will become a valid record correction. And we must always have the duplicate copies of various things: OPD paper, referral slips, transfer paper, information to police, investigation slip, and discharge summary. Discharge summary is very, very important that you take their signature also of the patient and the representative that they have received it and keep it there. Now, how long to keep the record is another question which is commonly asked. The record in general, unless until the case is going on or the medical legal cases are there, 5 years in general is good enough. For the pediatric cases, they say when the child become adult and after 2 years after that, so that means for 21 years. So I really pity the pediatric surgeons, but in general, 5 years is good enough. Now, how to destroy the record? The legal procedure is that you should give advertisement in the newspaper that we are going to destroy the records from this point, this time to this time, year of last 3 years or last 5 years and all this, and give it in a very small advertisement in the 2 local newspaper, which may not have a very big circulation or whatever, but it is there. And after that 1 month period is over, you can destroy the record. So I believe this is the time to change the Hippocratic Oath. One of the things is there that for the benefit of my patient. For benefit of my patient, it was there. It is there. It will always be there. But I would suggest not at the cost of my skin. Every one of you have a beautiful skin. Try to protect your skin because that is very, very important. So take-home message would be honest to yourself and your patient. Keep good medical records. Always take informed consent. Don't be a very good salesman in taking the consent. Don't take case beyond your capability. Don't take case beyond the capability of your setup. Like I say many times that I may be one of the good urologists. I may probably be at par with the best in the world. Probably you can say there is no problem in that. But my setup is not up to the mark in that way. I have a small nursing home of 10 beds. I do not have an ICU. I do not have a cardiac support. So if a patient who is having ejection fraction of maybe 15, 20, 25%, and I want to do a TURP, and if I am doing at my place, it is a negligence per se. If there is any problem, I would be in the soup or I should be in the soup. Then I should take this patient to any of the hospital where the cardiac ICU is available, where the cardiac specialty is available, and there I can operate. For the surgical part, there is no issue, but for the operative and the post-operative part, my setup is not sufficient. So don't take any case without full workup and cover yourself and the hospital with professional risk management and indemnity insurance. And please prevent preventable medical errors. Thank you. Thank you very much.
Thank you, sir. Thank you very much for your elaborate presentation. And I think all those who have attended and will watch later on the YouTube also will get benefited. If anybody want to ask any question, you're welcome.
There are two things that I would like to add. Number one was that whenever this thing is there are two things. Whenever good number of the hospitals are nowadays NABH, and they have a very elaborate system or documents of the consent taking and various record keeping. But what I have seen is that though documents are there, so many documents are there, but they are not filled. They are all empty. So any empty record is a very bad one. That the patient's signature is there and nothing is written anywhere. And nowadays is the era of the mobile phone where everybody can take the picture. So that means that empty records or the incomplete records, incomplete consent is not very proper. That is number one. Number two, that many times I want to think about is that about the timing of the consent. Like I said, there should be an opportunity for the patient to be able to digest the things that you have said about the counseling, possible complications and risk and failure. And they should be given enough opportunity to withdraw the consent. This is especially in reference to the ophthalmology one. What happens is that they have to go for a cataract surgery. 7 o'clock, they would be reaching there. 7:10, their consent is taken. 7:20, they are in the theater. 7:30, this surgery is finished. 7:40, they come to the post-operative room, and 7:50, they are discharged. So at least on documents, it should have sufficient gap between a consent taking and the operating procedure. If it is mentioned that 7:10, the consent is taken, and 7:40 or 7:30, the operation is done, and 7:50, the patient is discharged, this is a short material for the litigation.
I'd like to add one more point, sir. For anesthesia complaint has to be totally separate from which we used to be a common consent that is no more valid now. A separate consent has to be taken for anesthesia procedure and its pro and con and complication and everything to be mentioned.
I understand totally
Yeah.
with you, but I am not aware about any judgment which says that the anesthesia should be taken separately. If you are aware, please let me know about that judgment. But of course, I understand that NABH requires it is there that it should be a separate consent. Ideally, yes, a separate consent is a must. What on a practical level, even what I am practicing is I take the signature of whoever in the consent, where I am putting my signature, I take the signature of the consent, and we have a common consent for both together. And I think that it is reasonably defendable. It is reasonably defendable. If there are any court case which says that there should be a separate consent, I would like to be aware of that.
I think the reasoning beyond that for that is anesthesiology is a separate specialty, and you have to tell the patient all the pro and cons and complications of the.
Yeah.
And as surgical consent, surgeon is required to sign, so anesthesiologist also should sign that consent.
Yeah.
So that is the NABH
That is
has
ideal. I
taken it on.
entirely agree.
Yeah.
This is ideal. But that is what I'm saying, that there could be a practical things in there, that in the common consent that we are following, we can always write about the anesthesia and its complication, need to change from one anesthesia to another anesthesia. Maybe you are talking about the spinal anesthesia and it is you are not able to give spinal. Then you have to go for the general anesthesia. That everything and the possible complications are documented in this only, and the signature of the anesthetist is also taken. That is a via media. I entirely agree. Ideal would be have to have a separate consent altogether. But I am not aware about
Sure.
any judgment where the doctor or the anesthetist or the surgeon has been penalized because of not separate consent.
Okay, sir. Thank you, sir. Thank you very much. If there is no question, so we can close the session. Thank you again very much.
Okay. Thank you.